Attendees are in listen-only mode.
Welcome, everyone. Thank you for joining Fielding Graduate University and the Worldwide Network for Gender Empowerment, or WNGE, for the webinar series Challenging Structural Inequalities and Disparities in Women's Health, Intersections of Gender, Class, Race, and Nation. I'm Kirsten McGregor, Associate Director for WNGE, and this webinar is the second in the series of 3 Women and Health events. For the past decade, WNGE has been working on critical issues around the globe focused on gender empowerment issues. WNGE is engaged and diverse ecosystem comprised of global members committed to research, collaboration, and action in support of women's and gender issues. Our mission is to impact change in critical areas including education, poverty, healthcare, environment, violence prevention, equality, and globalization. WNGE is also a UN non-governmental organization, and as an international NGO, we represent global partners and contribute to issues of critical concern to the global development agenda. Today, our webinar event is titled Gender Equity, Reproductive Health, Infant Mortality, and HIV/AIDS. Our agenda follows 3 general segments. First, an introduction to our panelists, which is then followed by 2 presentations. And then we'll have a moderated panel discussion with Q&A. We won't be addressing the questions during the presentations, but please submit them, and we'll be sure to answer them during the last segment. So today, to moderate today's discussion, we have Dr. Anna DiStefano. Good morning, Anna. I'm handing the presentation over to you.
Thank you very much. Good morning, everyone, or good evening, or good afternoon, depending on where you are joining us from. It is indeed an honor to moderate the panel today with Dr. Vamsi Vasareddy and Dr. Anamona Munteanu, and to share this experience with all of you, whether you are live with us right now or whether you are listening to the recording. I am going to try to fairly rapidly introduce Vamsi and Anamona, and then get out of their way so that you can hear them share their expertise and experience with you. At the end, I will talk a bit about the situation in the United States. We are also joined by my fielding colleague, Dr. Margot Okazawa-Ray, who, in her own inimitable way, may make some comments at various points throughout the moderated portion of the webinar. Thank you. So let me move to introducing Vamsi, who is a medical doctor with an advanced degree in public health. He is currently Senior Health Advisor for the CDC, based in Tanzania. He has previously served as Principal Investigator for a Gates Foundation project in Africa and Asia. Those are among his many accomplishments and roles. Today he's going to focus on maternal, newborn, and child health. And I do want to say that his presentation will include some images that I personally found powerful and disturbing, and so I'd like to give you a bit of a heads up about that. The second presentation will be from Anamona, and she is currently a psychotherapist in private practice, serving clients in Romania, as well as other countries in Europe and the Middle East. She was Director of Health Education earlier in her career for Youth, a Romanian NGO, and she has also worked for USAID programs and UNICEF. Today she's going to talk to us about how advocacy for women's rights to health can influence infant mortality. She'll really be talking about more broadly about her work as a change agent in this field. So with that as a brief introduction to our impressive panelists, I'd like to turn the presentation over to Vamsi Vasareddy, our first panelist. Welcome, Vamsi, and take it away.
Thank you so much. Welcome, everyone. I really appreciate all of you taking the time to to log on today. Before I start, I would like to alert you to a few things. One, I'm a physician by training, which means we all speak fast. So if there is any time that you want me to slow down, please let me know through your comments or through your questions online. I will try to speak slow. The other thing is, if the line is not clear or anything, please let the organizers know as well. I'm calling all the way from Tanzania, so sometimes there can be technical issues. Having said that and getting that out of the way, let's go ahead and get started. Thank you for the wonderful introductions. As Anna and Kirsten mentioned, I am Vamsi Vasireddy. I am currently working as a senior health advisor for the Centers for Disease Control at the U.S. Embassy, based at the U.S. Embassy in Tanzania. I focus mostly on HIV/AIDS and service delivery for HIV/AIDS and how we can strengthen service delivery in Tanzania in order to respond to the HIV/AIDS crisis. But part of that, that advisory role and strengthening the health services is also working on the maternal and child health aspect of HIV/AIDS. As we know, we focus a lot on reducing the transmission from mother to child, and also preventing the transmission of and new infections of HIV in Tanzania. As many of you may know already, sub-Saharan Africa has one of the highest burden of HIV/AIDS in the world. So we are doing a lot in our capacity to address that situation. But what I will be talking today is more on the side of social inequities and the challenges women face in these countries to access healthcare services, and less about what the technical aspect or the medical aspect of it. So having said that, please go to the next slide. Okay, so I wanted to give a little bit of background to the audience about maternal mortality ratio, which we commonly use as an indicator for a nation's health. We see that even in the news, even in the mainstream media, being reported as to how MMR is an indication of how a particular country is doing in terms of its health systems, its health status, and how much investment is going into health. You may have followed the big articles that came out from CDC, from New York Times, from the World Washington Post, everywhere, showing how the United States government spends so much money on healthcare, yet our maternal mortality ratio we are not even in the top 10 of the best countries that address maternal mortality ratio. So to give you an idea, MMR, as I will refer to it from now on, maternal mortality ratio, MMR is used as an indicator of how a particular country is doing in terms of its health status. How we define MMR is the number of maternal deaths for 100,000 live births. So for every 100,000 children that are born live, how many mothers have died in order to give birth to those children? That's a ratio that has been established as an indicator for a nation's health. Among the many, MMR is one of the many indicators. But according to the WHO, this is a very staggering amount, and please allow me to get on my soapbox when I talk about this. It's a very passionate issue of mine. Every day, 800 women die across the world trying to give birth. This is not acceptable. Like, no woman should die trying to bring life into this world. That is not acceptable for anybody in this world. This is something that we should be really passionate about and concerned about. And it bothers me all the time when I see so many fundraisers happening for different issues that have very low disease burden, And I look at it and I'm like, do you all realize that there are every day, every single day that we wake up, and by the time we wake up and go to bed, around 800 women in this world die just because they're trying to do something that is natural to them, and they're trying to bring life into this world. It is something that should bother all of us. But that's the status of being a pregnant woman in this world. Like, you have a very high chance, if you are in sub-Saharan Africa, which is the most dangerous place in this world to give birth, is sub-Saharan Africa, because the 10 countries that have the worst MMR in this world are in sub-Saharan Africa, and it is really a very dangerous place in this world. If you are a woman living in sub-Saharan Africa, childbirth is a traumatic experience, and it is a very dangerous experience as well. Next slide, please. So focusing strictly on Tanzania, because this is where I'm based at this moment. I've worked in other countries, but as of last year, I'm based in Tanzania. Tanzania has a very high maternal mortality ratio, 410 maternal deaths per 100,000 live births, which means for every 100,000 children that are born, 400 women die in order to give birth to those children. And 6% of those are directly attributed to HIV and AIDS. And regardless of what causes the maternal death, the main contributing factor, what ties all these maternal deaths, is access to healthcare. Having a clinic, or even a lesser facility where a pregnant woman can go have a safe childbirth is a rarity in this part of the world. It's very rare for a woman to just, like, when she's ready to deliver a child, to go and find a clinic that is accessible. Some women travel for hours, for some of them even for days, trying to get to a clinic so that they can just deliver a child. However, not many of them have that resource, so they end up delivering at home or in the traditional methods, which are attributed as one of the main causes for maternal deaths in these countries. And one of the reasons, one of the major things that we can fix, is making sure that there is a trained provider. And it doesn't have to be a physician. It doesn't have to be an OB-GYN, as in the Western world. It does not have to be a trained physician. It can be a nurse, a midwife, who is trained in regular obstetric practice. That's all we need to make sure that that's even simple childbirth can be harmless, does not result in death. And also, the other issue that we have found research has shown to decrease the number of maternal deaths is access to contraception. Because if you look at a lot of these countries, the data shows that most of the maternal deaths happen in women under the age of 20. And if you can target that age group and make contraception available to that demographic, you can prevent a lot of maternal deaths. And that is one thing that we constantly try to address in the countries where the US government works. Next slide, please. So I wanted to show you this picture for the audience to show you an idea. And this is actually not even a low-level healthcare center. This is actually a district hospital in Tanzania, which is considered like a better status of health hospitals. It is where people go from different regions to a district. It's like for example, for the audience who are from the US, it would be something like a county-level hospital, where people go from different, a state-level hospital, where people go from different counties to get specialized care. And if you can see in this picture, there are not enough beds, and the women are laying on the floor. And one woman is actually, the one that is laying on the floor is actually just delivered a baby. And this is the status of healthcare clinics. This is what I'm talking about when I say access to healthcare. There are not enough clinics, there are not enough clinicians to provide healthcare. So the few health centers that are available are extremely crowded, and women end up like basically sharing whatever bed is available so they can just have a place so they can deliver a child. And I have always been amazed and just stricken by like at loss of words for these women who all the resilience they have in order to just deliver a child. All they're trying to do is bring a life into this world, and the risk that they go through and the trauma that they have to go through so that they can bring life into this world is just astounding. And you'll see when you are in the clinics that the strength, the power, the resilience that these women have in order to give birth to a child, and it just makes you speechless and makes you just stop everything you're doing and work to make sure that they have access to the healthcare centers that they need. Next slide, please. I wanted to also show you some numbers, since you know, being a physician with a doctorate in public health, I make sure that we have the data to back our statements. And this is a contraception in Tanzania. You'll see that if you see the percentage of sexually active unmarried women who are using, like, who have the unmet need, a third of them do not have access to contraception. And if you look at the married women who are sexually active, you see at least a quarter of them have no access to contraception, and which means that these women have a high risk of getting pregnant, which means they may have unwanted pregnancies, which have a very high unwanted pregnancies are cited as one of the main reasons for postpartum hemorrhage and thereby causing maternal deaths. So the data shows that the access to contraception is extremely limited in a country like Tanzania, which is considered better than many countries. The next country that I'll be talking about has even worse data in terms of contraception and maternal mortality rate. And Tanzania is considered somewhat better compared to other countries. And this is what the world considers somewhat better. For us, this is not acceptable. This is horrible. Contraception is something that should be available. A woman should have the right to choose when she wants and does not want to have a child. And if you do not have that access to make the decision, you risk the chance of getting pregnant, and an unwanted pregnancy is not always a good outcome, especially in this part of the world. Next slide, please. So I wanted to highlight one of the reasons why we have such high rates of maternal mortality and why the access is so low. You'll see that Tanzania, according to the WHO data, the World Health Organization's data, has 3 clinicians for 10,000 people, whereas the recommended rate, the least acceptable number recommended by the World Health Organization, is 23. In order for you to be at the lowest level of delivering healthcare services, you have to have at least 23 clinicians per 10,000 people, whereas a country like Tanzania has 3. That itself explains to you why there is such high lack of access to a trained clinician in order to deliver a child. And research has traditionally shown that women are very less likely to travel to a clinic to healthcare because many of them have children or family at home that they need to take care of, and they cannot always travel to a clinic which is not easily accessible. Which traveling to a clinic means that they have to find child care for their existing children, and they usually also are the caretakers for the rest of the family. So they have to make sure that there is enough care for the rest of the family before they travel like half a day or sometimes even 1 to 2 days just to reach to a clinic. And this is not always feasible in a country where you being a woman are the primary caretaker, and you can't leave your children and your other dependents in the household and go and to deliver a child. So a lot of these women end up delivering at home, which raises the risk of maternal deaths. And you'll notice when you go out into the field that many women working in the fields and working labor-intensive tasks or even to the last week of pregnancy, they're still like doing extremely labor-intensive tasks because that's their livelihood. They cannot afford to miss work even just because they are pregnant. It's not an option for them. They need the money. They need to feed the other children in the house. So you'll see a lot of women working labor-intensive work even to the last day, just the day before their delivery, which also adds to the stress of childbirth, leading to like various health issues. And this is again, this is the the reason why I mentioned this under inequities. Inequities is, you know, the country health system as a whole cannot guarantee access to healthcare, which is an inequity in itself because of the lack of clinicians. And then on the other hand, women do not have the necessary resources or the support systems to travel far to deliver a child because they are the caretakers at home. Next slide, please. So I don't want to preach too much to the choir here, or I don't want to make it sound like we are we are the saviors here. But I just wanted to give you a quick outline as to what we are doing in terms of the U.S. government work to address these challenges. One of the things that we do from the U.S. government side, through CDC at least, is to strengthen. We work very closely with the Ministry of Health in Tanzania to strengthen the service delivery, especially in the area of maternal and child health and addressing HIV/AIDS. A lot of the money we invest here goes towards healthcare and addressing the HIV/AIDS crisis and making sure that maternal mortality is reduced. Some of the, there is a lot of work for us to do, but we have made considerable progress in decreasing the HIV prevalence from 5.7 to 5.1 in 4 years. And just to remind you of what I said in my earlier slide, about 6% of the maternal deaths are attributed to HIV/AIDS. So if we can reduce the prevalence rate of HIV/AIDS in these countries, we can also reduce the maternal deaths that are happening because of HIV/AIDS. And also, if we reduce the prevalence of HIV/AIDS, we can also reduce the transmission of HIV during pregnancy to the child, and so thereby ensuring that the child is born free of the virus and they have a better chance of survival. And because of multiple efforts, the maternal mortality rate has actually decreased in Tanzania from it was 460 in 2010, and the projection for 2013 was 410. It may not look like a huge decrease, but a decrease of 50 deaths per 100,000 live births in 3 years is very significant in a country like Tanzania. So we are working hard. We are still going strong at addressing the HIV/AIDS crisis and also making sure that women get the services that they need. We train a lot of healthcare workers in countries so that they can be deployed to regions where there are no healthcare workers to ensure access to healthcare, especially childbirth, immunizations that are especially like delivering children, immunizations, and basic clinical care. So there are a lot of training institutions that have been set up with the help of US government and also other NGOs to address this issue. Next slide, please.
Vamsi, I think this is Anna. I think we probably should take about 5 more minutes on the situation in Liberia and then move on to our next presentation.
Okay, great.
Thank you.
So next country that I wanted to bring to attention 2 countries. One was Tanzania that you just heard about, and the next one is Liberia. I spent a good amount of time in Liberia, and I designed their healthcare system after the Civil War. And this is one of my countries, one of my favorite countries, because it has suffered so much, and there is so much that we can do in order to alleviate the suffering. And I still, even though I don't live there, still do my part to help the healthcare system and the people of Liberia. It has one of the highest maternal mortality rates in the world. Almost 1,000 women die trying to give birth for 100,000 every 100,000 children that are born. It has some of the highest rates of sexual and gender-based violence, which I'll show you in a minute. Next slide, please. And this shows you, I wanted to show you this picture. It is very graphic. It is a picture from the Civil War of Liberia, and in the picture I was actually taken, the barbed wire that you see is the wire that is between the U.S. Embassy, the road that goes to the U.S. Embassy, and the town of Monrovia, which is the capital. This was during the Civil War. As you can see, the people that have been killed, most of the people are women and children. This has been a constant disturbing factor during the Civil War. Most of the deaths have been women and children. In any war, the one demographic that suffers countless number of times and has the most magnitude of suffering is women and children. And this picture is a perfect example of that. It's very disturbing, but it also gives you an idea and makes you think like it's always the women and children who suffer the most. Next slide, please. And I wanted to show you this picture as well from World Press, which shows why the sexual and gender-based violence is such a huge issue in Liberia. Women were always used as a pawn in the Civil War to inflict suffering and pain. And this picture is, although again very disturbing picture, it also captures this still happens to this day in these countries. This kind of a treatment of women still happens to this day in these countries. Next slide, please. So these are just a few numbers that will show you the amount of violence that goes on against women in a country like Liberia. Especially this can be attributed to other civil war-prone countries as well. You take Sierra Leone, you take Cote d'Ivoire, you take Zaire, which is DRC, Democratic Republic of Congo. And these numbers are, even though they are Liberia specific, you will see similar numbers in the other countries that are going through civil wars as well. I mean, almost half of the women have experienced physical violence since they were 15 years old. That tells you that the seriousness of the situation. And then the other numbers will show you that majority of the women in all age demographics have been raped at one point or another because of the civil war. Next slide, please. And this report was put out by the International Rescue Committee a few years ago, showing how in many countries we associate going to school with being a safe zone, but going to school in itself is a threat to girls in a country like Liberia, because passing the test, the real cost of being student, that was the title of the report. If you read the report, you'll see that most of these girls who go to school actually have to do sexual favors in order to move on to the next class, in order to pass an exam. They trade sexual favors, so just so they can get to the exam center, just so they can sit for an exam. It is so disturbing on many levels that you assume the children are going to school and they are getting, which education is going to solve the problems, but you see in countries like this, education is actually causing some of the problems, because in order to pass a test and sit and go through school, they have to return sexual favors, which is a very disturbing trend in countries like Liberia. Next slide, please. So again, I don't want to dwell too much in this, but there are many efforts that are happening right now, and they have been intensified because of the current Ebola situation in Liberia, to address this access to healthcare issues and addressing the root cause of the problem, which is basically there are many cultural issues that we from the Western world cannot fix. We should not fool ourselves into thinking that we are the saviors in Africa or South America or Asia. We are not. What we can do is help alleviate some of the problems by making sure that if a woman wants to deliver, if a pregnant woman wants to deliver a child, she has access to a clinic, a safe place where she can go deliver. If a girl wants to go to school, what we can do is make sure that there is a school in that part of the country where she can go and have a safe space to get an education and not worry about what kind of a sexual favor does she have to do to the teacher in order to just sit for an exam. Those are the things that we can work on, and that are the things that we are working on in order to address some of the issues and making sure that people in a country like Liberia can have access to healthcare. Next slide, please.
Have we lost Vamsi?
Yes, I think we've lost Vamsi.
Well, we can see this was the last slide in his presentation. I hope that he'll be able to rejoin us for the Q&A. I have lots of thoughts myself, and I'm sure others do as well. Let's quickly turn to Anamona's presentation. And Anamona, I would ask you to be as concise as possible so that people will have an opportunity to ask you questions as well. So, Anamona, you're on.
Okay, thank you so much for inviting me, and I'm honored to be here with all of you listeners, and also the team that helped me, as I said earlier, not to mess up with too much information. As Vamsi said, as a medical doctor, I tend also to speak too fast, but I'll try to be concise. And I worked for Mother and Children as medical doctor, as program manager, as health educator, and now as psychotherapist, I'm centered more on families issues. The presentation is called The Backpack of a Change Agent because this is what I would like to present, an issue and the sort of solutions that we found in Romania. We know that are not the only ones. Maybe they were not the best, but it was the best we could do. At very moment. Next slide, please. So Romania is in the southeast of Europe. It's the blue country near the Black Sea. And it's surrounded by Ukraine, Bulgaria, Hungary, and Serbia. Of course, Moldova in the east. So the root of the evil, it was the so-called infamous decree number 770 from 1966. The communist regime realized that with the existing birth rate in 1966, it was not enough labor force to fulfill all the requirements of the forced industrialization. So they introduced a forced pronatalist policy. This decree had many provisions, but the most harsh were that they were denying to women all form of abortions and denying any access to contraception. Including the sales of contraceptives through pharmacies was forbidden. Basically, it was an invitation to smuggling, and this really happened on the western border. Here, the link you have here is to a very powerful documentary, which is called The Children of the Decree. It's translating in English. For those of you who are interested in, I encourage you to see it. It's about 1 hour. Next, please. Okay. So what were the consequences? Of course, it had some results, the desired results by the communist regime, in the sense that the birth rate doubled in the next year, but women found ways to avoid pregnancies, and they were backstreet abortions. And women were terrified to go to the hospital. In general, if the backstreet abortion had unpleasant outcome and complications, and women were taken to hospital. They were denied any kind of medical assistance unless they were telling to a prosecutor and militia representative who did perform the abortion, and only then the doctors were permitted to help women. If they were not confessing, they were let to die, and it happened many times. When they did not go to the hospital and died there with law enforcement forces, they died at home. It is estimated that almost 10,000 women died because of this policy. The fact is that one never knows the real figure, because these 10,000 women somehow contacted the healthcare system, but many times the women that died home, they were just covered being like accident, or put it like some kidney disease or very severe infection, in order to avoid to imprison the person who tried to help the woman. But it was another result, another consequence of the decree. Not only that women died, but they were mothers, most of them. So over 25,000 children were abandoned and institutionalized. These were the children that were taken by their fathers to the state and then put in the institution, orphanages. But we really don't know how many children just were moved from parents to grandparents to other relatives, and or left just to exist on the streets, in the villages. Actually, we really don't know the number of children who suffered the consequences of the decree. The communist state wanted more children, but was not equipped to take care of them, and apparently it was a lack of concern about providing better healthcare services, because at some points in this period, Romania had the highest infant mortality rate, and it was just in an unwanted competition with Russia and Bulgaria. They were changing places from one year to another, but actually they have a very high rate. So the achievements of the decree: thousands of dead mothers, thousands of orphaned and institutionalized children, thousands of unwanted children, and soon it proved that the state had no education or healthcare facilities or medical facilities for such a large number of children. And then it started a downward spiral that we are facing its result even now. So these are children with actually the picture is from 3 years ago, but it's the same situation. Their mother one did not have money to go to hospital, and was not informed that she can access free services, and she had the backstreet abortion and died. And these children, these beautiful children, were left with their father. But this was the situation for many others. Next, please. These were the children in institutions, abandoned and neglected. This is an actual picture of that time. I think that is from 97, from 70s, late 70s. Next, please. Okay, so at the time, the unwanted children were abandoned, abused, neglected, and they did not represent a value for the families. I was asked at some point if we can estimate how many unwanted children there were. nobody did such a research, but just speculating, the number of births tripled in the next year of the issuing of the decree. So if the birth rate maintained, the number of births maintained for the last 3 years prior to the decree issuing, tripling the number, we can just speculate that this was the number of unwanted children. So what we have now? We have these unwanted children, middle-aged individuals who are the fabric of the active society, and they show all psychological trauma of unwanted children. It's a social and psychological unrest in the Romanian society, and more and more studies are starting to link this with the psychology of the unwanted child. And I've seen also in my practice people around in their late 40s coming saying, actually nobody wants me and I'm a failure, and it's not just a person, it's almost a mark of a generation. And also many of them have this mentality of social assisted person, and unfortunately was supported by populist policies of the last 25 years governments, and these people are waiting for somebody to provide for them. Unfortunately, this hits women as well, because they are waiting for somebody else to take care of their health, and are not actively looking for services that have been put in place. Of course, they are not the best services and they're not at European standards, but they are, and women are not accessing them even as they are. Next slide, please. So this was for children. The reality for women was that women were subjects of two types of violence. The so-called regular violence that is in any patriarchal society, abused by husbands or boyfriends, violence in the society. But they were also subjects of the legal violence, because in large industrial units, women were checked every single month for pregnancy. A doctor or several doctors, depending on the number of the employees, came to the workplace, and in improvised cabinets, they performed mandatory gynecological checkups. And this was, I'm repeating, every single month. And if a woman was suspected to be pregnant, immediately she was she was registered and checked up not to have an abortion. So any single individual involved in illegal abortion was sentenced. The woman, the doctor, the midwife, the relatives, all of them. And again, this is why we do not have the real number of abandoned children, because not only the children of the dead women were orphaned, also the children of imprisoned women suffered because their mothers were not at home for 7 to 10 years. All forms of contraception was banned, and this is the image of imposed motherhood. Looked like a farm. Next, please. Next slide, please. Yes. And this is one of the instruments. Women were really lectured by the party meetings. It didn't matter if they were party members or not, about their patriotic duty of motherhood. Every 2 other months, they were gathered in large forums, and they were spoken at, and the order to give birth to children was given to them. Next, please. So what has been done? First of all, I have to say that international financial and technical support was instrumental. The Romanian society at the end of 80s had no means to develop any kind of project, nor had the knowledge or the know-how. So what the strategy that was chosen was to train technical specialists, equipping them with data and with communication skills. Why technical specialists? Because they were the ones who could speak both ways, upwards to the policymakers and downwards to their colleagues and to population. So they were the key instruments, let's say, the key people to spread the word and the knowledge. And a massive change initiative was implemented. And why I'm saying massive, because really it was important also in number, in structures, in targets, doctors, pharmacists, nurses, administrators, and managers, and politicians, at the same time with the same message, and also involved organizing civil society. That meant supporting NGOs, grassroots NGOs at that point. Now they are creating a coalition, our former baby NGOs. And the civil society, the NGOs, moved quicker than the governmental structures. Also because in the governmental structures, the change was, in health department, it's a never-ending story. There were 25 ministers in 22 years, ministers of health. Another intervention was creating the health insurance system. They introduced new services in the health structure, and these are services that the state is paying for, the reproductive health services, reimburse specific services for women and children. Next, please. How? So basically, the advocacy was important, but was done simultaneously with central and local authorities. Communication campaigns, creation and growth of NGOs, and what was one of the most important elements was the synchronized intervention, advocacy and communication campaign, NGO development, talks to politicians. Next, please. And also, this is the lobby with the president of Chamber of Deputies. Actually, if you immediately after that, she immediately also a famous actress testifying for children and mothers. That meant to involve public figures or political figures. Next, please. And what now? The healthcare system has improved, but severe underfunding, and there is this tendency to cut healthcare expenditures. Infant mortality rate decreased to this incredible 8.5 per 1,000 live births, but still it's triple the European average. And this is one of the champions, one of the doctors who is militating for mother and children health, for reproductive health of women, and the result is that newborns are cared for. Lessons learned is that have been many achievements, but the main lesson is that no change is permanent. Without supporting effort, there is slippage, and unless the change is institutionalized, it has has very few changes to remain. And now we are facing an unprecedented uprising of a religion conservative trend that it's hardly counterbalanced, but NGO, it took us by surprise. And the key to all changes are the people. They are the real champions. Next, please. So basically, what do you, if you engage in a change, in a project, just have the communication skills to get to them, meaning your targets. They do gather your data, your facts, understand their fears, and be there to explain and not to impose. Plan with the mind, but speak from the heart to their hearts. And it's dedicated to all female children all over the world, our efforts, so they can reach their best version of themselves.
Thank you so much, Anamona. We're probably going to go about 15 minutes beyond our scheduled time, but I'm going to just quickly, Kirsten, go to the next slide and then the next slide, just to say that the U.S. infant mortality rate is higher than any other 27 wealthy countries, according to the latest report from the CDC, and a baby born in the U.S. is nearly 3 times as likely to die during her first year of life as one born in Finland or Japan. Next slide. You can see the countries that outrank the U.S. there. Next slide, please. Next slide. I'm really wanting to make some time for questions. And it's important here to look at the variation among the states in the United States and think about the relationship to other factors of income, race, religion, and how they influence the access to healthcare and to contraception and abortion throughout the United States. You can see some pretty significant concentrations in the South and actually in the Middle Atlantic Midwest in terms of problematic areas. Next slide, please. And you can see the relationship of this to income and economic circumstances. Next, please. So, finally, we've arrived at the time for panel discussion. I have so many things I want to say, but I want to give Kirsten an opportunity to tell us what our audience is thinking, but I'm going to ask Margot. Margot, if you'd like, I'd like to give you the opportunity to either make a comment or ask a question, and then we'll move to the ones from the audience. And if there aren't any, I have a few of my own. So, Margot, any thoughts?
Yes. Why don't we go ahead and take the audience questions, and then if there's time, I'll jump in. Of course, I have a comment. Okay, but
of course you do.
The audience, yeah.
Of course. Kirsten, do we have any from the audience right now, or should Margot and I go for it?
Yes, we do. Let me start with one, and then we will go back to Margot. This is from David Willis. Thanking everyone for an excellent presentation. His question concerns next steps needed. In your professional opinions to improve maternal health and infant mortality in all countries, including the U.S., and also, why do you think the U.S. is doing so poorly in infant mortality and maternal health?
Well, I should defer, of course, to the experts, Vamsi and Anamona, but I think this relates to some of the questions I was going to ask about. First of all, the centrality of a woman's right to control her own reproduction through contraception, abortion, family planning seems to have come out in both of the presentations in very powerful ways. And I was going to say interference. I think that that's actually a right thing to say. The interference or intervention by the state and or religious organizations in curtailing that access. seems to me to be something we really need to be vigilant about upstream. So, I mean, I think when you have state organizations, and I mean national and local state organizations who restrict access to contraception, health care, and abortion, I think you set up these kinds of situations, as both Anamona and Vamsi have talked about. I also think that I'm wondering, and it came out for me in Vamsi's presentation, but I'm wondering about its applicability in the United States as well, which is, Vamsi, you talked a lot about access to clinicians and healthcare from trained clinicians. And I don't know exactly how to ask this question, so I'll ask it sort of a bit clumsily, which is, I'm wondering about pushing out more expertise and support to sort of community-based midwives or other kind of community-based organizations. Can you hear me, by the way, Kirsten?
Yes, I can hear you.
Oh, okay, and Vamsi, okay. So I guess I'm just wondering about, rather than relying on women coming to healthcare, I'm thinking about healthcare training coming to them. And so I don't know whether that's a sort of an old countercultural idea or whether it's a feminist idea without much merit, but I'm a little bit leery about focusing on the increased sort of medicalization of the childbirthing process. So what do you think about that, Vamsi?
That's a very good question, and in my rush to finish the slides, I did not clarify what we mean by clinicians. Clinicians, the way we define it, is not just physicians or MDs. Clinicians are MDs, nurses, and even midwives. And as defined by the World Health Organization, they don't always have a medical degree, but they are trained in clinical practice. So, for example, in rural Tanzania, you will see a midwife who is not an MD, being trained on safe childbirth practices and delivering those services for a uncomplicated childbirth. Of course, complicated childbirths are always referred to an expert physician or a nurse practitioner, but uncomplicated childbirth is handled by nurse and midwives in many of these countries. It's a very interesting concept, and it has been tried to have lay health workers, community health workers be the first level of response for childbirth. But what research has shown us that the risk of maternal death is lower when the delivery is performed at a facility rather than home. So it's important to have a child delivery conducted at a facility where there are proper tools, proper trained midwives or nurses, rather than home, because home-based delivery, unlike Western world, if something goes wrong at a home-based delivery, there is no ambulance to come get these women.
Right.
So it's always safe to go to a facility to deliver where there is a trained clinician to deliver the child. But the role of community health workers in this process, and that we have piloted in many situations, is that they will function as a conduit, as a channel to get these women who are in remote areas to reach a facility where they can safely deliver a child. Rather, they will be the means, they will be the outreach, they will be the advocates to ensure a facility-based delivery.
Thank you. Margot, I think, has a comment.
Yes, sorry. I think we're talking about several levels of inequality, and Vamsi just mentioned one, which is the inequalities between rural areas and urban areas, and then within those, the various inequalities. And I think the question of health, I think, is the question of the whole larger problem of, so-called development, right? Where in many countries, including the countries of the global north, development has just been seen in terms of, the gross national product. And I think there's a real need to think about development being directly, the level of development being directly tied to things like the level of women's education, women's reproductive justice, etc. And I think the third piece that I think it's really important to mention is the ways in which, especially in the countries of the global south, and this applies also to the US and other countries of the north as well. And I don't think we in the US call it structural adjustment programs, but in essence, I think they're the same. Cutting back on health, education, all the things that have an impact, as our two panelists have talked about, on the health and well-being of women, right? And so the countries are required to take away subsidies for medicine and so forth, and instead, open up their countries for other kind of capitalist improvements or, capitalist benefits. And the last point is militarism, and as Vamsi said, has been, and wars have been a great spread of HIV, right? And as the bans of various state and non-state, military actors have, gone across borders and things like that, they've carried with them the HIV. And so in all these cases, it seems that women's lives don't matter, right? Or they matter to the extent they can birth children for the state, for the benefit of the state, right? And I think we've seen some of this rhetoric in the radical left movements, nationalist movements in the U.S., birthing babies for the nation. And so I think really looking at the macro and global factors to understanding women's health is really important. And I just saw a startling statistic that showed that Anna, you showed the chart, the differences, among the states. But I think within even the light blue states that you showed, if you disaggregate for places like Oakland, California, for example, or Detroit, Michigan, you'll see that the rates are very much correlated with age and income and race.
Right.
So I just want to point out those things.
Thank you, Margot. I was reminded of what you, or I think this comment is in keeping with what you just said, is that Anamona made the comment toward the end that to remember that the tendency of systems to revert back also, to think that on the macro level that you've made changes, but those changes are not permanent. In fact, they require constant sort of vigilance and reaffirmation, even when they come. I mean, I'm not suggesting that any of us are where we want to be in terms of protecting infants or women's maternal health.
Right.
But even when we make advances, those advances come under attack from, as Anamona was saying, now in Romania, from the religious establishment. So no longer is it the communist establishment, but now it's the religious establishment. So that we do need to think about both an analysis of these data on the micro level and also thinking about the macro forces that are keeping them in place. The other thing
and in both examples, they're both patriarchal institutions.
Right. No, exactly. And then the other thing that I wanted to comment on in terms of Anamona's presentation, but it's implied in a way in Vamsi's, is that these things not only have an impact in the moment, but then there are generations of consequences, generations of people who are affected by the policies of 20 years ago or 40 years ago, that whether it's trauma or other kinds of psychological or medical sequelae, things don't end when a particular policy ends or a new law is enacted or some new, program is put in place, that they extend back in time and forward in time. And it's a different kind of sort of ongoing challenge. Kirsten, do we have any other comments?
We have a
or
comment.
questions?
Yes, we have a comment from Kathleen Gillespie. Excellent overview of equality issues facing women in the world today. The challenges range from simple, quote, neglect to intentional predatory practices to structural inequality based on income. Many issues facing the determination that women's lives matter. That was the comment.
Thank you very much. Vamsi or Anamona, if you have a final comment, I'd be happy to hear it, and then we'll close.
Sure. I would like to add to what Mr. David Willis raised earlier as to why we have such a high rate of MMR in the United States, which is a developed nation. I think the primary issue in a developed country like the United States is that we treat healthcare as if it is a business. Healthcare is a basic human right, just like education should be. But in the United States, and I've lived long, I mean, that's my home base, but I'm always surprised and disappointed at the way the politicians, the general public, majority of the general public sees healthcare. They see it as a business. They see it as a way to make money. No, healthcare is a basic human right. Everybody should be able to have access to safe and quality healthcare. And in a country like the United States, where we have the means and the workforce to do that, to provide that quality and access to healthcare, there is no excuse why we cannot do that. And the way we treat both healthcare and education as a money-making entities is just wrong. And I think that's the primary reason why our healthcare indicators lag behind many other countries.
Thank you. Anamona.
Yes, I would like to say something about what Vamsi said in his presentation, that every day 800 women die. So let's think about the orphan children that are left behind. So it's not only 800 women dying, but also 800 families that are suffering. So it is, unfortunately, it's like a river that it's going bigger and bigger and bigger and carries away lives and happiness and health and, of course, the state of a nation.
Thank you very, very much. And your comment is amplified by the fact that both of you talked about the role of women as primary caretakers for practically everybody else in the societies in which they live, except not for themselves, except there are no supports for those women being treated as the sort of central axis for caregiving, and instead they are treated as expendable by the powers that be, which, as Margot has said, are often patriarchal and unconcerned about their well-being. Kirsten, tell us about the last webinar in the series, and then we'll close.
Yes, okay. Well, thank you, everyone, for participating today. I wanted to remind you that there's going to be well, thank you, Vamsi and Anamona, first and foremost. That was a wonderful presentation. There will be a recording of this webinar, and it'll be available in the next couple of days, and it'll be posted on all the WING sites, the website, Facebook, YouTube, which are now shown on your screen. And we have our third webinar of the series on May 27th, so please put that on your calendars and save the date. We'll get that information out to you in the next week or so. And with that, I think I would like to wish everyone a great day or a relaxing evening wherever you are in the world. And we will see you next month.
Thank you very much. Goodbye, everyone.
Thank you.
Thanks, everyone.
Goodbye, everyone.
Bye-bye.
Bye, everyone.
Bye.